All right, Jesse Carroll here, ready to do another deep dive into something known as closed loop ventilation. There are a couple different forms of closed loop ventilation, but today we're going to go over the specifics behind adaptive support ventilation, otherwise known as ASV. So if you take a look at the middle of the triangle here, you'll see what I've indicated above is PRVC plus VS. The nomenclature identified there would be pressure regulated volume control plus volume support. Therefore, when you're on the spectrum of this triangle between the passive and the engaged patient, you're going to be interacting with the patient in a PRVC style of ventilation. That would be a target volume with an augmenting pressure to meet that volume, trying to improve patient synchrony when they're breathing, whether they're passive or they're engaged, i.e., if you have essentially a controlled mandatory ventilation or otherwise termed assist control, or a SIMV style of ventilation. Again, a targeted volume with an augmenting pressure. What's unique about this style of closed loop ventilation in ASV is that when you move over to the spontaneous side of this paradigm, you're actually met with something that's very powerful in that we get a volume supported spontaneous breath. And when that happens, the patient's spontaneous breathing now has its own targeted volume and augmenting pressures. Whereas, in contrast, traditionally in conventional styles of ventilation, when we allow patients to breathe spontaneously in your take your SIMV with pressure supports, that's exactly what's happening. Is those spontaneous breaths are being given with a set pressure support. This could become problematic over a period of time, especially if the patient has any sort of active, either acute or chronic lung condition that they may be faced with. So let's talk a little bit deeper about how to decipher the nomenclature and understand what's really going on when you're utilizing ASV with the Hamilton technology vents. More specifically, why ASV can become super valuable in the use of ground and air rescue EMS to simplify mechanical ventilation strategy. It's really important to note that when you're using a Hamilton T1, C1, MR1, any of the Hamilton technologies, and you're implementing ASV, when the patient is passively breathing, you're actually providing essentially, depending on the nomenclature you've selected, if you were to look at the mode section and you look under volume control, you'd either be delivering adaptive pressure ventilation, controlled mandatory ventilation, which would be APV, CMV, or if you've chosen the other nomenclature, you would be delivering synchronized controlled mandatory ventilation. All we're saying is essentially is no synchronized breathing in this passively breathing patient. No pressure supported breaths either. So essentially a patient that is receiving all of the mechanical breaths from the ventilator and they cannot initiate any sort of spontaneous breathing. Now, moving on. If they're engaged, you would see something like an APV SIMV. Again, APV standing for adaptive pressure ventilation. Just another term for PRVC, which we already went over earlier on in the video. So, or it could be an SIMV plus, similar to VC plus, right? That you may have seen in some other ventilator terminology out there. The long and short of it is that we're really simplifying all of this nomenclature by calling this ASV, or adaptive support ventilation. So at no point on this continuum is your patient not being supported. Okay, so the way ASV treats the patient is we actually treat the patient based off of a percent minute volume. As you may know, if you've worked with any of the Hamilton products, once you select the gender and the height of the patient, the ventilator is going to automatically identify the ideal body weight for that patient. Therefore, if we're ventilating at 100% minute ventilation, you simply move the decimal over one place, and you'd be providing that many liters of support minute ventilation over a minute for the patient. For example, I'm a 5'9" male. I have an ideal body weight of 71 kilograms. If I were on the vent on ASV, I would be supported for up to 7.1 liters per minute of minute ventilation when I'm being supported at 100% minute ventilation. So, what is minute ventilation for those of us who aren't quite sure what makes up minute ventilation? So, if you look over here, I've got minute volume, otherwise termed as VE, okay, is made up of respiratory rate multiplied by tidal volume. And while obviously this is the significant portion of how to manipulate somebody's ventilatory status, it is not all of the variables that need to be included or understood. There is an additional variable, a ventilation variable known as TI, or inspiratory time, that does come into the fold when we are conventionally ventilating a patient. So again, part of the reason why we're doing this education to better understand this is we're looking at the utilization of ventilation strategies in the pre-hospital space that can actually help us reduce our workload and our cognitive load. Most of my rescuers and my medics that are out there are not familiar with the nuances between volume controlled and pressure controlled breaths. This can become extremely problematic even on those shorter transport times, which we all know that there's no true 4-minute transport because we have to include scene time and delivery time of acceptance into the facility. So usually what I like to ask is, what is your average time that you're spending, your contact time that you're spending with these patients, right? So that being said, keep in mind, if something dynamically changes in transport, and we're ventilating a patient in some sort of conventional ventilation mode, my medic or my rescuer or anybody who's interacting with the patient is going to have to be able to make an on-the-go decision of which ventilatory change should I make to get the best case outcome for my patient, and how do they know if once they make that change that that's not going to dynamically change just a few minutes down the road. Whereas in the use of ASV, what's actually happening is that, again, we're managing the ventilation by targeting CO2 and augmenting percent minute volume. So what that looks like is, let's do a quick example. Let's say we've got an intubated patient that's on ASV, and we know, as I mentioned, that we're delivering 100% minute volume to the patient. And we notice on our side stream capnography that our patient's CO2 has risen to 60. And that to us in our protocol is not acceptable. So we're going to put the current CO2 on the monitor as being measured at 60 millimeters of mercury. Well, again, as I mentioned, we know that that's not acceptable. And so we say, okay, how do we want to change the patient's CO2 to help improve their clinical condition before they continue to deteriorate? Okay, well, let's say my desired CO2 for this particular patient, just for our intensive purposes, is 40. We're just going to keep it simple. I'm going to go ahead real quick, and I'm going to grab my calculator. And I'm going to take 60 multiplied by 100, which equals 6,000. And then I'm going to divide that by 40. That gives me a new percent minute volume of 150%. So now we've eliminated the guesswork involved in having to choose between a respiratory rate, of a tidal volume, or an inspiratory time to get an optimal outcome as far as CO2 is managed. Now, so at this point, we're going to go ahead. Our new percent minute volume would be 150%. So titrating to a target CO2. This helps my rescuer to make much quicker and more informed decisions based on true clinical data that they have that will produce actionable results instead of delaying the onset. For example, in this same scenario, right? Let's say they saw the CO2 of 60 and they were on some form of conventional ventilation, call it AC, right? And they had a respiratory rate of 16. And what I see often is this tidal volume of 450, between 450 and 550, let's call it, and maybe an I time of anywhere from 0.9 seconds to 1.1 seconds. Well, now the CO2 is 60, and the rescuer has to decide whether or not they want to change respiratory rate, tidal volume, or inspiratory time. Secondarily, they have to make that change within whatever their protocol guidelines are that their medical direction has provided them. So about 95% of the time, the answer that I get from my medics that they want to change is respiratory rate. They want to increase the respiratory rate to drop the CO2. And there's actually an equation for that to see how much you would have to change the respiratory rate to get the CO2 to change. But that's just part of the equation. That doesn't take into account the particular disease process that the patient's dealing with, meaning that you can put that answer into the equation and you still might not get the full change that you're looking to get. So let's say they put it into their equation and it comes up and says, hey, you need to change the respiratory rate to 22. So we change the respiratory rate to 22, and now our CO2 changes to, let's call it, because there is a disease process that, again, the equation can't take into account. So let's say the CO2 drops to about 52. We just told you that the target CO2 is 40. Well, we're still 12 millimeters of mercury away from that target CO2. So now the rescuers, it's 5 minutes have gone by. Their end title's still not reading where their target is based off of what their protocol is. They've got to make another adjustment. And now they're starting to second guess themselves. They're like, well, I just increased the rate. I don't know if I should increase the rate again. And my next step would be to potentially change the tidal volume. But I'm already at a tidal volume of 450. And so now, again, there's an equation for that as well. So let's say they put that into the equation, and now we've changed the tidal volume from 450 to 500. 5 more minutes go by, and the CO2 is now 45. Still, now we're probably in an acceptable CO2. The rescuer may, or the medic may not do anything more at this point because they're concerned that they've already made multiple adjustments and they're not that far off. Okay, but my point being is that all of this has an impact on the patient care. And secondarily, something that we overlook way too often is the workload and the cognitive load that this has on the medic or on the rescuer. If they are taking the time to conventionally ventilate a patient during patient transport, they are limited in their capacity to dress lines, to address the cardiac monitor, to chart, to safely belt and buckle themselves in the back of an ambulance and manage the patient appropriately. They are sitting there triaging a mechanical ventilator from a conventional standpoint in something that they are not traditionally trained in. Hence why ASV and closed loop ventilation become extremely valuable in scenarios like this. So I'd love to teach you guys more about this. I'm going to do some more deep dives coming up into how do I know how to choose between CPAP and BiPAP. And you may be shocked at what my answer is going to be, but most of the time you're probably going to want to choose BiPAP. If you're really looking at the patient care tree and recognizing that the majority of our patients that we're interacting with don't just have CHF and they don't just have OSA. They have multiple comorbidities to include metabolic conditions that are going to be better treated with the support of BiPAP. That's coming up in another video. Drop your questions down in the comments. I'm looking forward to answering.